In part 2 of this lecture, we are going to be taking a look at treatment interventions. So the first that we'll discuss is therapy, and so obviously this has become popular to provide in a treatment program. A lot of times there's a therapist on staff, or at least referrals made to mental health providers so that clients in recovery can access this sort of service. And so individual, group, and family therapy are important components. And of course, if you have taken or are going to take Addiction Studies 15, the Intro to Counseling class, you'll go obviously a lot more in depth in this topic, but just to touch on it a little bit. So of course, individual therapy is going to be that one-on-one with a client and a therapist, and a lot of it involves exploring the reasons for why there's been continued use of these psychoactive substances, and really identifying the ideas behind changing this behavior and how to support changing this behavior. So that's provided to the client through individual therapy. And group therapy also accomplishes those aims, but it also brings in the added component of helping bring people together and breaking that isolation so that these individuals know that they're not alone, they're not the only ones going through this, and they're not the only ones trying to figure out how to live their lives without a substance anymore. And so that group can really provide a lot of support to one another. And then family therapy is also important, and so that can help to increase the acceptance and understanding in the family of being able to recognize that addiction is a treatable disease. And it can help the family to imagine and establish goals and boundaries for being a drug-free family. It can help strengthen communication and interactions among the family members. And it can also be a chance to process and figure out how to readjust after sobriety and after this person is maybe back home if they were in a residential treatment facility. So that can all be really important within the realm of family therapy. And specifically, motivational interviewing is a really important counseling skill. It's one that's being used more and more among treatment providers, and so if you haven't heard of this counseling model already, you may definitely run into it in the work that you begin doing, and it's really good to have a good understanding of this skill. So motivational interviewing is based on these 5 basic principles, and the first is to express empathy through reflective listening. So when you're working with an individual, you want to make sure that you're doing your best to show that you are empathetic and you're invested in and care about what they're sharing with you. The second is to develop discrepancy. So there's the client's goals and their values and their current behavior, and those two might not always line up. And so the idea of developing discrepancy is that you're drawing attention to when those two things don't line up. So a client may be in treatment and they have the goal of remaining sober and abstinent, but maybe their current behavior isn't lining up with that and not in line with supporting that goal. And so you can, kind of draw attention to that and say, well, I hear you saying that your goal is to remain sober, but I'm curious about what was going on with this situation. And you can kind of draw attention to those things and kind of help the individual process that. Third principle is to avoid argument and redirect confrontation. So this is, you don't want to engage in, disagreeing with what the client says, or, even with the skill above of developing discrepancy. It's not something that you want to create any contention. So, if the client is going to provide that, then you want to not engage with those arguments and don't want to be directly confronting the client. The fourth is to roll with resistance. So again, rather than locking heads into that argument with the client, you don't want to oppose that resistance directly. You just want to roll with it, and not have it get in the way of still providing that space for the client to come and work through these issues. Even if they are going to be resistant, maybe they're not sharing a lot, you're still rolling with it rather than opposing it. And then the fifth is to support self-efficacy and optimism. So self-efficacy being the idea that an individual is capable and able to do something for themselves, and so you're supporting that in the individual. So they're not coming to you for you to fix them, but you're there to support them and help them figure these things out. So supporting that, and also being able to maintain and hold that optimism for the future for this person. And so there's some specific strategies within motivational interviewing that we're going to look at. The first is OARS, and so that's an acronym that stands for these 4 different skills. And so the O stands for open-ended questions. So you want to make sure when you're working with someone that your questions are always open-ended. So that means that they are not close-ended questions, which are going to end in a yes or a no. So instead of saying, "Did you have a good day?" they could say yes or no to that. But you can say, "How was your day?" And that kind of opens it up for them to share what's going on, rather than just answering yes or no. The second is A, affirmations. So again, positive statements, recognizing strengths, recognizing the things that they are doing well. The third is reflections. So reflecting back what you're hearing, reflecting back the emotions that are being shared. It's kind of fits in line with the idea of expressing empathy. So you're reflecting back what's being told to you, what's being shared with you. And then the last is S for summaries. And so this again is you're summarizing what's been shared. And basically the idea is that in summarizing, so it sounds like what happened was, and then you kind of provide that summary of what was just shared with you, is it gives the client a chance to kind of hear that back for themselves and to process it again now hearing it rather than telling it. And it also gives a chance to kind of check understanding, and maybe they say, you summarize back to them, and they say, well, no, that wasn't quite it, it was more that this is what happened, and so it can kind of make sure that we're both on the same page. And then the second two, the readiness ruler and the decisional balance, we're going to talk about in the next slides. So the readiness ruler is a tool that can be used, and it's basically a graphic, or you can just ask it as a scale that can be used to kind of help someone gauge where they're at in terms of their readiness. Their readiness to change. And so you can see that there's 3 questions here that you can utilize. The first one says, how important is it to you to change your habit or behavior? And then they can rate that on the ruler or on the scale from a 0 to 10. 0 being not important, 10 being very important. You can also ask, how confident are you that you can successfully change your habit or behavior? And the last question there is, how realistic is it that you can successfully change your habit or behavior? So this can be a good tool for kind of engaging in that conversation and helping assess where a client is at, and not only for you to have an understanding where they're at, but for that individual to have an understanding of where they're at as well. So you can ask questions as a follow-up. So like with the last question, how realistic is it that you can successfully change your habit or behavior? So they may say, well, it's a 5. I think it could realistically happen, but I don't really know. I've messed up in the past. I haven't been able to really be sober for a long time. So I would say it's a 5. So then you can ask questions around that and say, well, why a 5 and not a 6? Or why a 5 and not a 4? To really get them engaged in thinking about why exactly are they at that place. And then you can even ask questions like, well, what would it take to move you from a 5 to a 6? And so you're kind of just prompting them to kind of think through these different things about where they're really at, where they want to be, and what they might need to do to move along that continuum. The decisional balance is another tool that can be used, and this is basically recognizing the pros and cons and the cost and benefits that come along with changing a behavior. So you can see there's 4 boxes there. So the first is to identify the benefits of continuing the old behavior, and then there's the costs of continuing the old behavior. There's the costs of changing the behavior and the benefits of changing the behavior. So this can be a good tool to help the person think through what this change means. So for example, if they identify one of their costs of changing the behavior is that now they can't use alcohol to cope with their depression. And so then that can kind of start the conversation of, yes, you are losing that in a sense, but what else can we introduce, can we bring in to help you deal with your depression? So maybe they would think about seeing a therapist or seeing a psychiatrist for getting on an antidepressant. So it's acknowledging that there are costs and benefits to changing, and then it kind of gives you the chance to help work through them and figure out how to address those so that they don't become a barrier moving forward. So the next intervention I wanted to talk about is solution-focused therapy. And this can be a good way to structure your conversations with clients, even as a counselor. The focus here is really on looking at solutions rather than problems. And so the basic ideas here are focusing on competence rather than pathology. So again, focusing on what's working and what's been done well rather than what's wrong. It's finding a unique solution for each person. So knowing that there's not a prescribed, this is what works best, this is what you should do or need to do, but really working with the individual and figuring out what's best for them. Using exceptions to the problem to open the door to optimism, so helping them to see that, to think about times when the problem isn't as strong or isn't occurring, and so that can kind of open up this door to say, okay, there is a way out of this. There have been moments in my life where I don't need to use, where I am able to not engage in that behavior that I'm trying to change, and so that can help generate ideas about the solution. Using past successes to foster confidence. So again, thinking about the times when this particular problem wasn't an issue, or if it was an issue, were there things that you've done in the past to help this and to address this? And so you can help the individual to think back on what's worked in the past to help me deal with this. And that can help give them confidence that they can implement those strategies or similar ideas again to make those changes that they want to make. It's also looking to the client as the expert, so they're not coming to you for you to fix them and make everything okay. You don't have all the answers, but it's acknowledging that they have that knowledge and wisdom for what they need in their life, and they're the expert in their situation, and you're here to help facilitate that. Another idea is using goal setting to chart a path toward change. So again, focusing on goals and next steps really drives that process. And then sharing the responsibility for change with the client. So you're there with them, you're supporting them in making these changes. They don't have to do it alone. So the central philosophy, which was discussed by the 2 individuals that are accredited with coming up and kind of formalizing this idea of solution-focused therapy, Berg and Miller, they state that the central philosophy of solution-focused therapy is in these three basic rules. So the first being, if it ain't broke, don't fix it. The second is, once you know what works, do more of it. And the third, if it doesn't work, then don't do it again. Do something different. So those can be things that you're thinking about when you're working with clients, to help them figure out what works and to not make them feel like they have to change something if it isn't creating a problem in their life. And then when they found something that isn't working, then put that idea aside and try something else. So here's some kind of specific interventions within solution-focused therapy. So these can be questions that you are asking to clients when you're working with them. So one common intervention is to ask the miracle question. And basically what this is it poses the question, if a miracle happened to you in your condition, whatever it is, were suddenly not a problem for you, how would your life be different? So it's really engaging the person in thinking about what life would look like or could look like outside of this problem. The second is to ask about exceptions. So asking, are there ever times you've seen pieces of the miracle? Are there times when you've seen what your life could be like or is like without this problem? So maybe they could talk about times when they have been sober, if that's their goal. So they could think about maybe a good day at the park with their kid when they were sober. So that would be an exception when that miracle had occurred in that moment. And then exploring differences between the current status and the desired problem-free state. So an example of putting this into a question would be, what is the difference between the times when you can see pieces of the miracle and the times when you can only see the problem? So again, if they identified seeing that piece of the miracle as hanging out at the park with their kid, how is that different than the times when you can see the problem? So maybe that kind of speaks to the environment, who they're hanging out with. If they're not using when they're with their child, it might be a good idea to help them think about spending more time with their child rather than spending with the friends that they use with. So that can be how that question might play out. Another idea is to use scaling to determine how well the client thinks things are going, how willing she is to work towards the miracle, her confidence in her ability to change, and the steps needed to improve the situation from one rating on the scale to the next highest. So this is basically kind of what we talked about as well with the readiness ruler in motivational interviewing. So again, it's using the scale to help the person identify where they're at, why they're there, and maybe not a different level, and maybe thinking through, well, what would it take to get you to move from this 5 to this 6? And so asking those sorts of questions can be important in helping engage them in that thought process. Another idea is to take a time out. So for example, you might say, hey, I'm going to step out, maybe grab a drink of water, but while I do, I want you to think of the next smallest step that you can take that would bring you to the next number on the scale. So it's kind of acknowledging that a lot of times in therapy or counseling, it can be kind of an overwhelming process at times. And this gives the person a chance to just be with themselves and reflect and think through things without having the pressure of having to come up with an answer to tell someone right away, or maybe it's just kind of a time for them to go more inward rather than have to talk about something right away. And so that can be a good way to provide a little bit of a break of, stepping out of the room for the minute and giving them that prompt to reflect on. Another idea is to affirm client competencies. So acknowledging what they're doing well, acknowledging the strengths that you see. So an example is, tell the client, I'm impressed that you are sitting in that chair again after what you just went through. So in that example, they're kind of acknowledging that hey, even though things aren't necessarily going that great, you're still coming here and meeting with me, and that says a lot that you're invested in being here and you're invested in coming to treatment. So it's looking for the the strengths. An example I heard once is that a client was sharing with the therapist about how they had relapsed and they drank 10 beers that night or something, and the therapist's response was, well, that's great that you didn't drink 11. And so reflecting on that strength there, that there was something that kept you from drinking the 11th beer, and so it's just finding the strength in whatever's going on. Um, and the last is to suggest tasks. So giving ideas of what the client can do to help improve to improve their situation. So maybe asking them to do something achievable that would provide useful information or move them closer to the miracle that they had discussed. So you can, provide ideas or help facilitate that conversation around thinking of specific and concrete things that can be done. So maybe part of their miracle involves having a job, and so you can maybe suggest tasks of going to the job market to find out what jobs might be available, or to meet with a vocational counselor, or have them think of other ideas that would help move them towards that goal of gaining employment. So other treatment interventions can be found by looking at evidence-based practices. And the idea behind evidence-based practices is that they are these interventions that have been tested and researched and that show a good amount of support for the idea that they're effective and that they're helping to create change in people's lives. So I listed a few links here. These come from SAMHSA's website, and so they have a good database of different evidence-based programs. So I'd encourage you to take a look at that. There are a lot of different curriculums and things out there for substance use disorder treatment and other things like addressing trauma or building parenting skills, or other areas that different evidence-based programs and treatments can be provided. And another intervention that has become more utilized in this day and age is medical intervention, and we discussed this a little bit last week. But to kind of review that, so medications are being used more and more, and they can be helpful with lessening withdrawal symptoms. So an example for this is clonidine for opiate and alcohol withdrawal. They can lessen cravings. So for example, bupropion for nicotine cravings. They can also provide a substitute that's less damaging than the primary drug of choice, so maybe methadone instead of heroin use. And then medications can also provide assistance toward reaching wellness, so maybe a nutritional supplement or an antidepressant can be used to help build up wellness in that person's life. And we can also look at complementary treatment services, so a variety of different outlets and programs and techniques that can be used to help support wellness in a person's life, and that can be really important when we're thinking about recovery. So there's a list of a lot of different things here. Some of them may be more evidence-based than others, and some of them may be a good fit for someone and not so good of a fit for someone else. So they're just different options that can be discussed or talked about with the client, or maybe they're options that a treatment program might consider providing, and they are going to have their merit on some level or of another for certain individuals. So it's just kind of a way to think through some other treatments and supporting treatments that are out there. And then lastly, we'll talk about some obstacles to treatment. So the first is developmental arrest and cognitive impairments. So the idea behind this is that we know that psychoactive substances can change or have an impact on someone's emotional development and on their cognitive development. We know from brain scans that there's definitely changes in the brain structure or the chemistry of the brain that can occur, especially with prolonged substance use. And so that's something to think about when we are looking at treatment, because a lot of these treatment programs are going to require someone to set goals and think in a very problem solving manner, or make a lot of decisions, or be able to sustain their attention for a group session or something like that. And we have to recognize that because of someone's substance use and the impact that it's had on their brain, that those might not be something that a person can really commit to and engage in. And so what's kind of being noticed is that 3 to 6 months of continuous absence is about the time that's associated with the return of those cognitive processes, where there's a lot less impairment there. And so that's something just to be sensitive to and to recognize when you're working with people that are maybe have just entered treatment, that there definitely can be an obstacle there because of the physiological effect that the use of that substance has had on them. So that's definitely something to keep in mind. A second idea is conflicting goals. And so an individual's goal may not be the same as the program's goal. So a lot of times a program is going to want complete abstinence from a person, but maybe that's not where that individual is at. Maybe they're looking to reduce their substance use to a less problematic level, or they're okay with still using a certain substance but willing to stop using another substance. And so there can be that conflict between what the individual is wanting and the expectations of what the program is wanting from them. Another obstacle is poor follow-through. So this is, obviously going to be an issue with people dropping out or not complying with all of the rules and expectations put forth by a treatment program. A lot of times this may be seen with mandated treatment, that if people aren't as invested in entering treatment at this time, that can lead to some poor follow-through. And so it's just something to keep in mind. And then, of course, the biggest obstacle is going to always be that there's a lack of facilities that can provide treatment. There's a lack of funding for more treatment facilities and resources. So that's always going to have an impact on the amount of services that are able to be offered. We've discussed before how when someone is ready to enter treatment and willing to enter treatment, and then they find out that there's no space for them, they have to go on a waiting list. That a lot of times can be a time when someone gets lost in the process, that they were ready at that point, but there's not a bed available, and so, X amount of time progresses and they don't have entering treatment at the forefront of their mind at that time. And so it really is important that we get the proper funding to be able to provide these treatment resources to our community. All right, and so that concludes this week's lecture on substance use disorder treatment.